I am.
I am.
From Bachelor of Science in Nursing,
And we are about to tell you.
The vital topics that pregnant woman must pay attention.
So please lend us your eyes and ears as we starting our discussion.
Good day, Mom. I am Shiela Perral, and I will be the one to tackle the first topic, which is the problems of passageway. So during a vaginal delivery, the baby passes through the dilated cervix and pelvis of the mother. For some babies, this trip through the birth canal does not go smoothly. Birth canal issues can make vaginal delivery difficult for women. So if this is recognized immediately, these issues can help deliver the baby safely. Passageway problems increase the risk for cesarean section and decrease the possibility of a safe vaginal birth. Evidence of a passenger passageway fit problem might include abnormal dilatation or descent, posterior ascendlitism or excessive caput, and molding of the fetal head or head trauma. Multiple vaginal examinations can result in an ascending infection, an overheated fetus, and fetal or maternal damage or death when attempting a vaginal birth, especially when labor is obstructed. Uterine rupture, as well as maternal and fetal morbidity and mortality are other risks associated with obstructed labor. Know the factors of the mother that increase the risk of operative vaginal birth and cesarean section for the best maternal and fetal outcomes. This topic will be further explained by me and with the help of my other group mates in the next video. Fetal presentation, the part of the fetus body that leads the way out via the birth canal, is referred to as fetal presentation, or what we call the presenting part. The head usually leads the way, but the buttocks or a shoulder might also take the lead. Head first, also known as the vertex or cephalic presentation, is the most frequent and safest position with the face and body tilted to the right or left, neck bowed forward, chin tucked in, and arms crossed across the chest. Labor may be more difficult and vaginal birth may not be possible if the fetus is in a different position or presentation. So there are different fetal presentation that an expecting mother should understand. As you can see in your screen, there are 7 presentation that has different indication. So I would like to explain each of them concisely. First presentation is settling into position. While babies twist, stretch, and tumble during pregnancy, before labor begins, they usually settle in a way that allows them to be delivered head first, or what we call cephalic presentation, through the birth canal. Second presentation is the head down but facing downward. The baby's position refers to the relationship of its presenting body part to the pelvis. In head first presentations, or cephalic, the back of the head or the occiput is the reference. The third presentation is the head down but facing upright. This baby is presenting head first or cephalic with its head facing up or occiput posterior. In this position, the baby might have a harder time extending his or her head from under the pubic bone. So most babies eventually turn on their own if there is enough room. If the baby is in this position and the second stage of labor is taking too long, the healthcare provider might reach through the vagina and use his or her hand to help the baby rotate, or what we call manual rotation. The baby might also be delivered in this position. The fourth presentation is the frank breech presentation. A breech presentation occurs when the baby's buttocks or feet or both are in place to come out first during birth. Breech presentation is often determined by fetal ultrasound at the end of pregnancy. So this could be further discussed in the following videos. The fifth presentation is the complete breech presentation. This baby is in a complete breech presentation with both hips and both knees flexed. In an incomplete breech, one or both hips are not flexed, and one or both feet or knees lie below the buttocks. In either presentation, you might feel kicking in your lower abdomen. Sixth presentation is the lying sideways. This baby is in a transverse lie positioned horizontally across the uterus rather than vertically. In a transverse lie, the baby's back might be positioned. This topic will also be further discussed by my other groupmate in the next video. The last fetal presentation that I would be showing to you is the twins. Twins can usually be delivered vaginally if the lower twin is presenting head first or cephalic. If only the lower twin is head first, as shown in the screen, the healthcare provider might deliver the lower twin vaginally. Then the healthcare provider will rotate the remaining twin by placing his or her hands on the abdomen of the mother and applying pressure or external cephalic version and deliver the baby vaginally, or if the baby is breech and certain conditions are met, deliver the baby buttocks first. If this can't be done, healthcare provider will discuss delivery by cesarean section. So that would be all for the fetal presentation. Let us proceed to the types of fetal malposition, which is the subtopic of the fetal presentation. Let's hear from Miss Marjorie Gijapon.
Hi, my name is Marjorie Gijapon, a BSN2 student, and now let us proceed to the types of fetal malposition. First is the occiput posterior. Fetal occiput is oriented toward the posterior aspects of the maternal pelvis. It means that if your baby is in the posterior position, you may be in more complicated delivery. This term refers to the fact that the back of your baby's skull, the occipital bone, is in the back or posterior of your pelvis. It is the most common fetal malposition. And the second is the direct occiput posterior. Occiput is posterior and does not deviate from the midline of the maternal pelvis. It means that your baby's head is down, but it is facing the mother's front instead of her back. It is safe to the delivery of a baby facing this way. Next is the right occiput posterior. The baby's back favor mother right and the back of baby's head is toward the mother posterior. The right occiput posterior is the common of four posterior position, and it is observed more frequently than left occiput posterior and direct occiput in the second stage of labor. And the next one is the left occiput posterior. Means that the baby is facing forward and slightly to the left, looking toward the mother's right thigh. It is the left occiput posterior position. This presentation can lead to the more back pain and slowly progression of labor. And it is also observed more frequently than right occiput posterior and direct occiput posterior in the first stage of labor. Now let us proceed to the occiput transverse posterior. Fetal sagittal suture and fontanelles are aligned in the transverse maternal pelvis. In the right occiput transverse, when the baby is facing outward toward the mother left thigh, the baby is said to be the right occiput transverse. And in the left occiput transverse, when facing out toward the mother right thigh, the baby is said to be the left occiput transverse. This position is halfway between a posterior and anterior position. And that's all for the problems of passengers and for the types of fetal malposition.
So that was the types of malposition. Let us proceed to the nursing care for mothers whose babies is experiencing malposition. Let's lend our ears to the discussion of Miss Josel May Pandy.
Nursing care of clients with malposition. So first, we need to observe closely for abnormal labor patterns when the power is not enough to patient, so we need to give her the Phytosins. also the passenger and the pelvis. So when the pelvis are have 4 types. So depending on the patient's experience, so we need to observe that, because it is difficult for patients to give birth of her baby. Second, we need to monitor fetal heartbeat and contractions continuously. We need to monitor FHR, that helps to detect changes in the normal heart rate, labor pattern. If certain changes are detected, steps can be taken to help treat the underlying problems. Third, anticipate for safe assisted birth. Fourth, anticipate cesarean birth for incomplete breech or shoulder presentation. Giving the cesarean section is to reduce the risk of the infant, such as the fetuses, if the positions is in breech, rather than head first in the birth canal. Fifth, be prepared for childbirth emergencies such as cesarean section, forceps assisted delivery, and neonatal resuscitation. 6. We need to position the patients in 3D leanboard or knee chest position. Positioning a patient for surgical procedure involves reducing risk of injury and increasing comfort, and it allows the greater access to the pelvic organs and helpful for procedures like gynecological, etc. So the last nursing care, we need to manually raise the presenting part aseptically.
After knowing the nursing care, let us also give emphasis to the nursing management of malposition. So to explain about that, here is Miss Alrish Pomoy to give you an additional understanding.
Malpositions are abnormal positions of the vertex of the fetal head relative to the maternal pelvis. Malpresentations are all presentation of the fetus other than vertex. The problem, the fetus is in an abnormal position that may result in prolonged or obstructed labor. The medical management make a rapid evaluation of the general condition of the woman, including vital signs like pulse, blood pressure, respiration, and temperature. Assess fetal condition. Listen to the fetal heart rate immediately after a contraction. Count the fetal heart rate for a full minute at least once every 30 minutes during the active phase, and every 5 minutes during the second stage. If there are fetal heart rate abnormalities less than 100 or 180 beats per minute, suspect fetal distress. Provide encouragement and supportive care. Note, observe the woman closely. Malpresentations increase the risk for uterine rupture because of the potential for obstructed labor.
So that is all the subtopics of fetal presentation. Let us proceed to the other main topic, which is the fetal malpresentation. So before I start discussing, I would like to define first malpresentation. Malpresentation can mean the baby's face, brow, buttocks, foot, shoulder, arms, legs, or the umbilical cord are against the cervix. This could increase the chance that the mother will need a birth intervention such as assisted delivery or what we call the instrumental delivery. This is when the doctor will help in the birthing process by using instruments such as ventouse or vacuum extractor or forceps to help the mother deliver the baby. Also, cesarean section, a surgical procedure to deliver a baby through a cut in the mother's abdomen or tummy and uterus or the womb. it is very important to know about the lie, which is the relationship between the longitudinal axis of the fetus to longitudinal axis of the uterus. There are different types of malpresentation, and these are the breech, transverse, oblique, unstable, and phonic or cord. Malpresentation occurs in about only 1 in every 25 pregnancies. First-time mothers are slightly more likely to experience malpresentation than other mothers who have already had a baby. Malpresentation is also more common in mothers over 40 years old who have had a previous breech or who are carrying twins or expecting a multiple birth. Malpresentation normally diagnosed when the doctor or a midwife feels the tummy of the mother, or it can be diagnosed through an ultrasound. So if the mother is 36 weeks pregnant, there are possibility that malpresentation can be corrected by gently turning the baby into a head-first position. But after 37 weeks, this could not be possible because there is not already enough room for the baby to move around. That was all about fetal malpresentation, and now let us proceed to its 4 subtopics for further discussion. Let us now hear from Miss Desiree Pastera for the bro presentation.
In an ideal vaginal delivery, infants are born in the vertex position. This means that they emerge head first with the chin tucked toward the chest. So the bro presentation is one of many abnormal positions that can lead to labor and delivery complications and subsequent birth injuries. A fetus in bro presentation has the chin untucked and the neck is extended slightly backward. It is similar to face presentation, except the neck is less extended. As the term bro presentation suggests, the bro or the forehead is the part that is situated to go through the pelvis first. Vaginal delivery can be difficult or impossible with bro presentation because the diameter of the presenting part of the head may be too big to safely fit through the pelvis. Risk factors and conditions associated with bro presentation are multiparity or having previously given birth and premature delivery, and fetal anomalies such as anencephaly and absence of major parts of the brain and skull, or anterior neck mass or a growth on the front of the neck. And last is previous cesarean delivery and polyhydramnios or excessive amniotic fluid. Infants swallow amniotic fluid while in utero, but this may be difficult if their neck is extended. So these are complications of bro presentation. If bro presentation is diagnosed in a timely fashion and is appropriately managed, there are typically no serious negative effects on the mother or baby. However, if medical profession also fail to recognize bro presentation and intervene as necessary, there can be lasting consequences, and infants may suffer oxygen deprivation due to prolonged labor or traumatic injuries from a difficult delivery. Some of the most severe conditions resulting from mismanaged bro presentation. This includes hypoxic ischemic encephalopathy, cerebral palsy, periventricular leukomalacia, and seizure disorder, and last is this developmental disabilities. So, the management of brow presentation is infants who assume a brow presentation early in labor may spontaneously move into a more optimal position during the delivery process. Additionally, safe delivery in brow presentation may be possible if the infant is unusually small and or the mother's pelvic opening is unusually large. For these reasons, physicians occasionally recommended vaginal delivery of infants in brow presentation.
I hope you are enlightened by her explanation. Let us proceed to the face presentation that will be discussed by Emallyzaa Pabia.
Hi, I'm Emallyzaa Pabia, a second-year nursing student. Now I'll discuss about face presentation. First of all, let's define face presentation. It is a rare obstetric event characterized by a longitudinal lie and full extension of the fetal head on the neck with the occiput against the upper back. It is an abnormal form of cephalic presentation where the presenting part is mentum. What causes this malpresentation? It occurs due to extension of the fetal neck instead of flexion. Causative factors associated with a face presentation are similar to those leading to general malpresentation and those that prevent head flexion or favor extension. Possible etiology includes multiple gestations, grand multiparity, fetal malformations, prematurity, and cephalopelvic disproportion. Moreover, incidence of face presentation is rare, accounting for approximately 1 in every 600 of all presentations. These risk factors may be related to either the mother or the fetus. Maternal risk factors are preterm delivery, contracted maternal pelvis, platypeloid pelvis, multiparity, previous cesarean section, and black race. While fetal risk factors include anencephaly, multiple loops of cord around the neck, masses of the neck, macrosomia, and polyhydramnios. For diagnosis, it is usually diagnosed during the second stage of labor when performing a digital examination. Based on the position of the chin, face presentation can be further divided into mentum anterior, posterior, or transverse. For palpation of the mother's abdomen at the start of labor, palpate the occipital region. A cleft between the head and the back will be palpable due to hyperextension of the head. On vaginal examination, no suture or fontanelle can be felt. Orbits, nose, mouth, ears, and chin is palpable. Palpation of the chin is essential to confirm diagnosis. Diagnosing the exact presentation can be challenging, and face presentation may be misdiagnosed as frank breech. To avoid any confusion, a bedside ultrasound scan can be performed. However, we must be careful because repeated vaginal examination to assess the presenting part and the progress of labor may lead to bruises in the face as well as damage to the eyes. Furthermore, face presentation can be delivered vaginally only if the fetus is in mentum anterior position. More than half of the cases of face presentation are delivered by cesarean section. Lastly, complications. Many of the common conditions associated with face presentation, labor, and delivery involve facial edema, facial bruising, skull molding, breathing problems, prolonged labor, fetal distress, spinal cord injuries, permanent brain damage, neonatal death, HIE or hypoxic ischemic encephalopathy, where the basal ganglia are damaged, neonatal encephalopathy, umbilical cord complications, birth asphyxia, microcephaly, seizure disorders, low muscle tone, muscle disorders, and cerebral palsy. So here are the pictures of babies with complications due to face presentation.
It was well explained by Miss Pabia and cater all the needed information. Let us now proceed to Miss Jomalyn Rapada for the discussion of sensipital presentation.
The The sincipital presentation occurs when the larger diameter of the fetal head is presented. In labor progress, showed with a slower descent of fetal head. And to avoid mortality rate, the mother must be prepared for childbirth emergencies for a cesarean section due to the unnecessary labor.
Last but not the least is the vertex presentation that I will be discussing right now. So in vertex presentations, the head of the fetus most commonly faces to the right and slightly to the rear. This position is said to be the most usual one because the fetus is thus best accommodated to the shape of the uterus. It is also labeled as normal in delivery. So this would be the last topic for the problems of the passageway. But there are still lots of discussion after this. So stay and focus for the next topic.
Hello everyone, my name is Nimfa Salado, second-year nursing student from Surigao Education Center. Today, I am going to discuss what breech presentation is all about, which includes the types and maternal risk and its complications. Without further ado, let's start. Breech presentation occurs when the baby's buttocks or feet or both are in place to come out first during birth. Breech presentation is often determined by fetal ultrasound at the end of pregnancy. Now let's proceed to the types of breech presentation. In a breech presentation, the fetus presents bottom down. There are three main types depending on the position of the legs. First is the complete or flexed breech, wherein both legs are flexed at the hips and knees, or fetus appears to be sitting cross-legged. Second is frank extended breech, wherein both legs are flexed at the hips and extended at the knee. This is the most common type of breech presentation. Third is the footling breech, one or both legs extended at the hip so that foot is the presenting part. Approximately 20% of babies are breech at 28 weeks of gestation. The majority of these revert to a cephalic presentation or head down spontaneously, and only 3% are breech at term. These are the maternal risk for breech presentation. First is a vaginal hematoma. It is a collection of blood that pools in the soft tissues of the vagina or vulva, which is the outer part of the vagina. It happens when nearby blood vessels break, usually due to an injury. Second is vaginal tear or perineal laceration. It is an injury to the tissue around your vagina and rectum that can happen during childbirth. Third is perineal injury. It is an injury to the perineum, the area of the body between the anus and the scrotum. It is a type of genital injury. The fourth one is low hemoglobin levels, usually indicate that a person has anemia. And the last one is the postpartum endometritis. It is an infection that some women develop after giving birth. The infection occurs in the lining of the uterus or in the endometrium or the upper genital tract. This postpartum infection is caused by bacteria. These bacteria may already be inside you before birth, or they can enter during the childbirth. Breech presentation is associated with an increased frequency of perinatal mortality and morbidity due to prematurity, congenital anomalies, which occur in 6% of all breech presentations, and birth trauma or asphyxia. And now, for the vaginal evolving of breech, let us hear from my groupmate, HoneyGrace.
Hello, I'm HoneyGrace in Pelandas, a second-year nursing student at Surigao Education Center. Today, I'm going to discuss about the vaginal evolving of breech. Vaginal breech birth is associated with a higher risk of perinatal mortality and short-term neonatal morbidity than elective cesarean section. Now, the common cause of breech pregnancy includes too much or too little amniotic fluid around the baby. In the last week of pregnancy, a fetus usually moves, so his or her head is positioned to come out of the vagina first during birth. There is a rest deduction in vaginal breech deliveries may lead to less skilled obstetrician and less favorable result in situation where vaginal delivery is unavoidable, such as undiagnosed breech in advanced labor or delivery of second twin. Breech deliveries were classified as planned vaginal breech delivery if the woman delivered vaginally or by acute cesarean section after the previous decision of vaginal delivery, whether the decision was taken before labor or after a phlebotomy in early labor.
For the external podalic version, let us hear from my groupmate, Jamela.
Hello everyone, my name is Jamela Andres, BSN2. So what is external podalic version? Internal version, the manipulation are performed exclusively through abdominal wall. Cephalic version, head is made the presenting part. Podalic version, breech is made the presenting part. So this is the indication, which is the breech presentation. Next, these are the contraindications: multiple pregnancy, antepartum hemorrhage, severe pregnancy-induced hypertension, planned cesarean section, gross fetal abnormality, scar on the uterus of previous surgery. So next, the prerequisite for ECV. Presenting part must not be engaged. Abdominal wall must be sufficiently thin to allow palpation. Gestational age more than 32 weeks, preferably 34 to 36 weeks. Next is the post-operative management. Bed rest in lateral position. Monitor fetal rate every 15 minutes for 2 hours. Monitor maternal vital parameters every 15 minutes for 2 hours. Watch for bleeding per vaginum, leaking, and abdominal pain. Next will be the complications. So these are abruption placenta, looping of cord, intrauterine death, premature rupture of membrane. So these are the causes for failure: too big baby, frank breech, obesity, and short umbilical cord. Thank you.
Hello everyone, my name is Adlawon, and for now I'm going to explain what is shoulder presentation and compound presentation. So let's talk first about shoulder presentation. What is shoulder presentation? So it is when the long axis of fetus lies transversely with the long axis of the maternal spine. As a result of shoulder of fetus occupies the birth canal. The position of the fetus are dorso-anterior, so it is more common, and a dorso-posterior. So the mechanics of the presentation is the long axis of the fetus is perpendicular to the long axis of mother, which occurs in transverse lie. Mostly, the shoulders presents in a transverse lie, but alternative presentation are the hand and arm. It may be prolapsed into the vagina, the cord, and the nil means the fetal back is down and above the level of the inlet. So for the etiology, the causes are in fetal is prematurity and multiple. Then liquor is polyhydramnios. Then uterine anomaly, especially the substitute of uterus. Then the placenta previa, and pelvis contraction, and tumor, and And lastly is the high maternal variety. The diagnosis in the case of shoulder presentation is to inspect the asymmetrical enlargement of the uterus. The abdomen is transversely broad, palpation, the fundal height is smaller than gestational age, then the fundal grape is absent, lateral grape, head of fetus in one side and breech on the other side. The pelvic grape is empty, and auscultation and then pelvic examination. And lastly is to investigate the ultrasound abdomen, pelvis at antenatal period. And immediate cesarean must be performed if the cord prolapse, early rupture of membrane, and the ACV failed. So the danger of transversalized for maternal are prolonged labor, obstructed liver, rupture of uterus, hemorrhage and shock, and lastly is the maternal death. And in fetal, cord prolapse, hand prolapse, IUD, fetal distress, and stillbirth. So, what is compound presentation? It is when more than one presenting part that enters birth canal at a time, or when a canal extremity prolapse alongside the presenting part, and both enter the maternal pelvis at the same time. So it should be vertex hand or cord, breech hand or cord, and vertex arm foot. So the causes in fetal will be the multiple and premature, and in maternal is multi-variety. For management, exclude cord prolapse that occurs in up to 20% of cases. Otherwise, expectant is the vertex foot. Try to gently reposition the lower extremity, and if arm prolapse in vertex hand, it needs to deliver by cesarean. So that's all for the shoulder presentation and compound presentation.
Hi, I'm Florence Nogaliza, BSN2, and today I'm going to share and discuss with you the nursing care to client with malpresentation. But first, let us recall what are the malpresentation. First is breech presentation, second, shoulder presentation, and next is cord presentation, and face presentation, and unstabilized presentation. So without further ado, let us now identify what are the nursing management to client having a fetal malpresentation. First, let us identify the management for breech presentation. So first, offer ECV or external cephalic version if there is no contraindication. If ECV is declined or unsuccessful, provide counseling on the risk and benefits of a planned vaginal birth versus an ELCS or elective cesarean section. This is an elective cesarean section. Next, inform the woman that there is fewer maternal complications with a successful vaginal birth. However, the risk to the woman increases significantly if there is a need for an EMCS. Next, inform the woman that cesarean section increases the risk of a repeat cesarean section and the risk of invasive presentation. Lastly, if the woman chooses an ELCS or elective cesarean section, document consent and organize booking for 39-week gestation. Now let's proceed to shoulder presentation. The general management for shoulder presentation is by administering IV fluid, blood grouping, RH typing, and cross-match at least one pint blood, and by giving parenteral antibiotics such as ampicillin and metronidazole. In obstetric management, in the antenatal and labor management, for antenatal management, if there is external cephalic version not contraindicated at 32 and to 34 weeks and fail repeat after 1 week, the vertex presentation is present. Well, if it's a normal vaginal delivery, then if it is revert back to the transverse lie, we need to elbow cesarean. During labor managing, if the baby is alive, we need to perform a CS, and on dead baby, we need to perform an internal pediatric version with breech extraction, destructive operation, and CS. And next, immediate CS must be performed if the cord prolapse, early rupture of membrane, ECV failed, and any delay in the progress of labor. And all of that must be kept in mind because there are certain things that changes during labor. So next, what is cord presentation and its management? The management of cord presentation aims to preserve the membranes and to expedite the delivery. Once the diagnosis is made, no attempt should be made to replace the cord. It is not only effective, but the membrane inevitably ruptured, leading to prolapse of the cord. If immediate vaginal delivery is not possible or contraindicated, cesarean section is the best method of delivery. So now let's talk the nursing management to phase presentation. So this part depends on the basically the face of the baby. So first, determine the orientation of the chin anterior at the mother's pubis or posterior. If the chin is anterior, vaginal delivery is possible, but the labor may take slow and patience is required. If uterine contractions are inadequate, oxytocin may be used. Also, episiotomy is usually needed during delivery, given the maximum amount of perineum can stretch. If the instrumental delivery is necessary, use forceps. Vacuum extraction is contraindicated for live fetus. If the chin is posterior, vaginal delivery is not possible. A cesarean section must be arranged, refer if necessarily. If cesarean section is not feasible and referral is not also possible, attempt the following maneuvers. First, flex the head to obtain a vertex presentation. With one hand in the vagina, grasp the top of the skull and flex the neck. Using the other hand on the abdomen to apply pressure to the fetal chest and buttocks. Obviously, the presentation part must not be engaged and it is often hard or possible to keep the head flexed. Finally, we're down to the last part, the unstable lie presentation. The management for unstable lie presentation first is admit patient to antenatal ward from 39 weeks expectant and perform a daily observation for the fetal lie, discharge if a longitudinal lie for 3 days, and review patient if in a week time and wait for the spontaneous labor. Next, usually 80% of patients without underlying cause will go to the linguintal lie with time. And active management for that, first is cesarean section at 39 weeks. If underlying cause found in the C-section at 39 weeks, perform ECV. And last is stabilizing induction of labor. So that will be all. Thank you for watching.